Okay, so we're going to do get our talk started with Dr. Catherine Varner, is coming up from Mount Sinai to talk about postpartum shortness of breath. Not everything is a PE, apparently. Usually I focus when I have these interactions with a patient, I'm mostly concerned with how the spouse is doing after the birth. It's a lot of stress for them and so forth. I focus on them. You make sure they're sitting, things like that. So I'm sure that's right, but you can tell them some more.
Thanks so much. I'm just going to get my clicker over here. Thanks so much. It is so nice to be back at EMU this year. I just want to say a big thank you to the conference organizers. I know you all put so much work into this, and I just want to say thank you. This is a gift to all of us, and the North York group are really the pillars of medical education, and I really can't thank you enough for being here. I am going to be talking about shortness of breath and pregnancy, and that it's not all PEs. And we are seeing a sustained rise in pregnancy-related morbidity and mortality in North America. This is a front page news story in the United States almost every week. We're not hearing a lot about it in Canada because we are undercounting. We don't know exactly how many women are dying related to childbirth. But this is a front page issue in the United States, to the point that the CDC has developed a campaign called Hear Her, that is to educate both patients and providers about the warning signs and symptoms of pregnancy complications like pre-eclampsia, sepsis, postpartum hemorrhage. And part of this campaign is to teach providers about unconscious bias. Because in the United States, what they have found is that women of color are 3 times more likely to die than a Caucasian woman at childbirth. And they are less likely to be listened to. And so we are teaching our patients and providers about the effects of unconscious bias. Unlike our peer countries, in Canada, emergency departments are part of pregnancy care because we see patients in the emergency department at times when obstetrical care that's ambulatory is otherwise not accessible to pregnant patients. So in that first trimester and in the immediate postpartum period, quite conveniently well before that antiquated 6-week postpartum visit. And these visits are not benign. We know that these visits mean that patients, even after adjusting for confounders, are at higher risk of perinatal morbidity, perinatal mortality, and stillbirth. The causes of these rise are cardiovascular causes. So we are seeing more hypertensive emergencies. We are seeing more pre-eclampsia, and we're seeing more peripartum cardiomyopathy. So let's dive into a case. This is a 33-year-old G2P2 who's presenting 5 days after an elective C-section. And by all accounts, everything went perfectly and was discharged from hospital on time. She's presenting with shortness of breath that over the last 3 days has progressed. She's now feeling scared to even hold her baby, particularly if she's moving, because it makes her so short of breath even to stand. She can't climb the stairs, and as she's talking to you, she's having a hard time completing full sentences. She notes that her lower extremities are like tree trunks, and they've gotten progressively more swollen. And what triggered her to come into the emergency department were the blood streaks in her sputum. If you take a look at her vitals, this is what jumps out to me. Her blood pressure is 174 over 110. Her O2 sat's 95%. This blood pressure means that this patient is at high risk of morbidity and even mortality, so pay attention to that blood pressure. When you take a look at her labs, everything is a bit abnormal. Her dimer's elevated, her LFTs are elevated, her troponin's slightly elevated, and she's got some protein in her urine. I'm going to pause right here because one of the things that I think we don't do enough of in a patient who's pregnant or postpartum in the emergency department is a chest x-ray. because I can tell you on a couple of occasions, I've diagnosed a patient with a pneumothorax who I was sure had a PE. And it's such a shame to send somebody to a CT to learn that they have a pneumothorax. So I would recommend doing a chest x-ray in a pregnant patient as a part of your workup of a patient who's pregnant or postpartum with shortness of breath. This is this patient's chest x-ray. Her heart looks a bit big. So I'm not going to stop here, but this chest x-ray informs where I'm going with this patient. So this patient is presenting with fairly typical congestive heart failure symptoms. So we've got a few options of what we can do next. We can administer some furosemide, call cardiology for a presumed diagnosis of peripartum cardiomyopathy. We can CT her chest to exclude PE. Treat her severe hypertension. Consult obstetrics for pre-eclampsia. Or we can do all of the above. This is a sick patient. We have a lot going on. I would vote that we do all of the above. And bring additional assistance to the bedside for this patient. In the emergency department, we will not be making the diagnosis of peripartum cardiomyopathy. We may be treating heart failure, but we won't be making this diagnosis because diagnosis requires an echocardiogram and exclusions of other causes of heart failure. But the good news for us is that we manage these patients like we would any other patient, any other adult patient with systolic heart failure. We know how to do this. This is our bread and butter. There are some additions to pregnant patients who are presenting in heart failure that you need to be aware of. You need to involve cardiology early. Recognizing that the pathophysiology of peripartum cardiomyopathy is a fast-moving, quickly evolving disease is really important in their management, because when you see them in the emergency department, they are at risk of getting sicker quickly. And so they need to be sent to a tertiary care center to anticipate that decompensation. In under-resourced areas, the mortality rate of a patient with peripartum cardiomyopathy is 30%. This is a deadly condition. In a resource setting, that decreases to around 6%. Transferring them to a tertiary care center is critical. What kills these patients are arrhythmias. Putting them on telemetry is important in your department. If you're identifying that this patient is developing arrhythmias, put the pads on. If you're transporting this patient, put the pads on. These patients are also at high risk of thromboembolic disease, so they need to be anticoagulated. This patient, I would therapeutically anticoagulate them while I'm waiting for the CT. If the CT is negative, then you'll be using preventive doses of thromboembolic events. I think this is such interesting pathophysiology. There is this dance that happens between prolactin that is upregulated and excreted in the immediate postpartum period, and then this uterine hormone called SFLT1. These two hormones together create a picture of endothelial dysfunction that makes the cardiomyocytes die in some patients. We don't really understand why. But it's also at a time when the cardiac output is still elevated. And so look when this happens. This is our time, 1 to 4 weeks postpartum. This is our time. And so this is why we are going to see these patients in our emergency department. And there have been so many accounts of patients coming in saying, I've got lower extremity swelling, it's not getting better. And the patient's being told, this is just normal. BNP, is it useful in these patients? It's more useful than in other heart failure patients that we see because there are very few causes of elevation of BNP in a reproductive age person. The caveat to that is that preeclampsia alone can elevate your BNP because it also is a disease of endothelial dysfunction. So you may have a patient who has preeclampsia and not heart failure, but their BNP is elevated. What about that D-dimer? I think it's important to emphasize that these patients are a high risk of thromboembolic disease. You need to think about doing that CT in this patient, even though you're diagnosed and are treating them as heart failure. So a D-dimer is really not particularly helpful for this patient. This patient had a negative CT. She went on to be diagnosed with cardiomyopathy. Her echo, she had a left ventricular ejection fraction of 35%. She was admitted to the CCU and then was discharged home on 3 different agents to manage her likely for the next 6 to 8 weeks as this was resolving. It was interesting because there was debate amongst the cardiologists as to whether or not she actually had peripartum cardiomyopathy, or was it just because her hypertension was uncontrolled. I think they were in disagreement. I don't think we'll ever know, but I think it speaks to how these patients can be on a spectrum. So our next patient, whom some would say are far less interesting, 39-year-old who presents 2 days after a normal spontaneous vaginal delivery, and her midwife sends her into the emergency department because she's now had 2 measurements of blood pressure, 165 on 90, 170 over 100. These blood pressure measurements were 2 hours apart, so the midwife advises the patient to come to the emergency department. The patient's otherwise healthy. She had an uncomplicated pregnancy. So what are your next steps? You could A, discharge the patient. Tell them to follow up with their obstetrical care provider in 6 weeks. Repeat the blood pressure in 30 minutes. This must be a triage effect. Administer nifedipine, 30 milligrams PO, and recheck in an hour. Or complete an assessment and workup for preeclampsia. I would suggest that we do both C and D in these patients. We have been taught that we should not be paying attention to adults with asymptomatic hypertension, and that's for good reason. Because when we start doing things to patients with asymptomatic hypertension, adults, we're gonna start causing harm. And I remember Amamatu on this stage 10 years ago giving some excellent advice, which is the best thing that you can do for an adult who has asymptomatic hypertension is turn around and walk away. That is not what we should be doing in pregnant patients. And I consider pregnancy-related hypertension entirely different than adult hypertension in adults who are non-pregnant. These patients are on a spectrum. Chronic hypertension is when you diagnose hypertension in pregnancy prior to 20 weeks. Gestational hypertension is after 20 weeks. Both of these patient populations are at higher risk of preeclampsia and HELP syndromes, and if untreated, these patients can develop the devastating consequences of eclampsia and macrovascular complications. So the diagnosis of hypertension in pregnancy now is 2 measurements of blood pressures 4 hours apart from one another of greater than 140 over 90. This updated guidance is based on a randomized trial that was published in the fall, where they used blood pressure targets that were either 140 over 90 or initiating treatment at 160 over 105. And what they found for the active treatment group, so targeting that lower blood pressure threshold to initiate antihypertensives, was that these patients had fewer bad outcomes, like preeclampsia, medically indicated preterm birth, placental abruption, fetal death, neonatal death. So we need to treat patients to address hypertension that's greater than 140 over 90 in patients who are pregnant. In the trial, they were using labetalol or nifedipine, either choice. There seems to be no difference in outcomes depending on which one you choose. Increasingly, I see our obstetricians using the nifedipine because it's a bit easier to dose, but there's no difference in how well they work. So I would encourage you to see and treat hypertension in pregnancy because part of this increase in perinatal morbidity and mortality has been related to untreated hypertension, which can lead to those macrovascular complications like hemorrhage and like vascular dissections. When a patient is still pregnant, so not in the postpartum period, you do have to be a bit mindful to not reduce below 110/80 because of the risk of placental underperfusion. And if you're treating severe hypertension in the department, so patients who have sustained blood pressures of greater than 160/110, these are some of your options. And in this era of waiting room medicine, I love PO nifedipine because I can dose it as a PO medication and I can repeat that dosing if needed without having to have them on a continuous monitor. So in this patient, we're administering nifedipine, rechecking her in an hour. We do a pre-eclampsia workup. This can all be done in the waiting room for this asymptomatic patient. Her blood pressure comes down after 30 milligrams of nifedipine. I'm going to discharge her, emphasizing the red flags. I'll have her follow up with her family physician. And then I'm also going to write a prescription for the next 2 weeks, understanding that she may need to be on this medication for longer. So in summary, treat and don't ignore peripartum hypertension. Use a chest x-ray to identify other causes. Think about peripartum cardiomyopathy, don't miss it. Use BNP to assist, but not make the diagnosis of peripartum cardiomyopathy. And patients with peripartum cardiomyopathy are at high risk of PEs. That's all I have to say. Thank you so much for letting me be here today.